Welcome to the Continuing Education module, How Worker Health Affects the Bottom Line, educating senior managers about the importance of wellness. Our module includes the following topics: a quick overview of the private employer sector. Secondly, economic issues and health-related costs. The third topic is factors that drive health-related costs. The fourth topic is pathways to lower health care costs and health-related costs. The fifth item is bottom line issues, and the sixth is a summary of key points. Let's start first with the size of U.S. employee population in 2015. Our total population, according to the current population estimates of the Commerce Department, is 322,762,018 people. So that's a large number, obviously, of people. The total labor force is 159,563,210 people, and that constitutes 49% of our overall population. So for every two people, one of them is related and working in a workforce or labor force capacity. Some important financial terms we want to look at, first of all, is after-tax profitability, and that's probably the best synonym for bottom line profitability. And it's defined as the after-tax profitability is an important financial performance indicator. It's calculated by subtracting all expenses from all income plus all tax liabilities, expressed as a total dollar amount. And that is for the profit-making sector of business in the U.S. Revenue surplus is a financial accounting term used in nonprofit organizations and governmental organizations to reflect the excess of revenues over expenses, also called net revenue. Required to assure that a nonprofit organization or a governmental organization is financially solvent and can grow over time. So these two areas, after-tax profitability is what the bottom line is for the profit-making sector. Revenue surplus or net revenue is the bottom line for our nonprofits and our governmental sector organizations. And health-related labor costs is defined as the combination of employee health plan costs, that's both the employer and employee portion, sick leave absenteeism cost, workers' compensation cost, short-term disability cost, long-term disability cost, and presenteeism-related cost. So those are the five major areas. The disability insurance includes both short-term and long-term. So if we count that as five, those are the five major health-related labor costs. Those labor costs are all subtracted from the income, which is either in the profit-making sector or the nonprofit sector and governmental sector. So that's our context for the financial terms that have to be looked at as we think about the impact of wellness on the bottom line of corporate America. Now, the bottom line for all U.S. business in 2015 for all after-tax profits reported to the Internal Revenue Service and then captured here in a composite, there were $5.95 trillion of after-tax profits for all profit-making companies in the U.S. And of that amount, all health-related costs, which are composed of the elements that the Bureau of Labor Statistics reports in its Employment Cost Index, and the addition of the Collins article on presenteeism conducted at Dow Chemical, which is one of the best methodological approaches to presenteeism, that has been applied and updated to the 2015 time period and dollars. And that constitutes $3.28 trillion. So if we think of all health-related costs paid by all profit-making businesses in the U.S., and then we look at their after-tax profitability, you can see that that relationship is approximately 55%. So when we think about working on the health of populations from a strategic economic perspective, we really can think about being efficient at helping people reduce health-related causes and losses that then have a direct potential impact on after-tax profitability. It's important to realize also that for the average company, or the average profit-making organization, they usually have to produce somewhere between $3 and about $20 of sales for each dollar of profit. So that really kind of equates as to how much new income they have to come up with, or revenue they have to generate if they're in a public sector setting that would require or meet this after-tax profitability. And that means that they would have to generate somewhere, again, between about $3 and $20 dollars of increased sales in order to produce $1 of profit. Whereas if we work on things like the self-insured health plan and actually reduce the cost of that, each dollar we save becomes a dollar potentially in after-tax profitability. So that's what makes the issue of wellness a much more strategic issue for America's business and governmental and nonprofit leaders. Now, the average employee cost in the U.S., if we look at the total compensation in 2015, it constituted this variety and it added up to this amount. So that means that if you took all of the wage and salary cost, which constitutes about 59% of total compensation in 2015 as reported by the Bureau of Labor Statistics, 22% of it of that entire amount of $95,463 was in non-health related cost, primarily benefit related, legally required and non-legally required benefits that are non-health related. When we look at the health related cost, it amounts to about 18.7% of that $95,463 on average for each working American. So the area where we attempt to use wellness to leverage is really in working on these health-related costs. That's the 18.7% that we're working on and can work on that's related to total compensation for the average American in 2015. Now, worker health cost perspective comes from the combination of several sources of information, the Bureau of Labor Statistics Employment Cost of Compensation Index, and then again the Collins article on Dow Chemical's presenteeism assessment, and some additional work that was done, the assessment of chronic health conditions on work performance, absence, and total economic impact for employers. That was reported, the Collins article was reported in the Journal of Occupational Environmental Medicine, 2005. And that information essentially covers the green area. So the Collins area really relates to the green area. I took their estimate from Dow Chemical, reduced it by half. So that's half the amount that they found in the study of Dow Chemical. And then the other side of the coin is the BLS data. And that's the health plan cost, which is about $13,000 on average. The $2,200 of sick leave, absenteeism cost, about $800 of workers' comp costs, and about $1,400 of disability, short and long-term disability costs. So these have been upgraded to 2015 using the Mercer employer survey results, which gives us an idea of medical trend over the years from the point on when some of this data was initially presented to the current time period. And then we also have the phenomena that we're spending somewhere around $36,000 on these elements of cost. And we oftentimes then want to spend $300 per year, less than 1%, on affecting these costs. So we're spending 1% to try and affect the trend lines and the future costs that are in this pie chart. So this is what we call the worker health cost perspective. And it's basically helping us see the national pattern and then encourage organizations to look at their own numbers and assess their own level of spending on health-related issues, which wellness programs are really intended to focus on and to reduce. This particular graphic is really key to us because it sets the stage for why the wellness issues should in fact be considered more strategic business imperatives, and also why we should be looking at them as more of a human capital investment or human capital improvement kind of strategy for business. Now, this particular graphic shows you the prevalence of key health risk factors. So we've backed off of the larger cost perspective to then look at what's some of the large-scale evidence. This is with 341,000 people, employees, and it's basically the new HERO study results. And it just shows you the percentage of the people examined in this 341,000 population that had the various health risk. So it starts out with body mass index. So 30% of them showed that they were at risk from BMI, that's overweight, obese, or one of the higher categories of obesity. Didn't exercise, 28%, had high elevated blood pressure, 11%, used tobacco products in a consistent way and consistent manner, and that was smoking related tobacco use, 10%. Glucose, 6.3, elevated blood glucose levels, elevated cholesterol, 5.6, and high levels of chronic excess stress, 4% reporting that. So this again is the new HERO study. We're looking at what we call the prevalence of health risk factors. Now, the other part of that study, major study, was looking at the percent higher cost of key health risk factors. So our new HERO study again shows the percent higher annual health plan costs. This is again over a 341,000 population, a very large population. The elevated glucose provides a 50% higher annual health plan cost from the person who is at risk versus the person who is not at risk. For elevated BMIs, we saw the very high numbers in the 30s. That's 31% higher cost. So 31% of the population have a 30 plus percent higher cost per average per year. Reporting excess stress, 27%. Tobacco use, 14% higher. Exercise, 5% higher. Alcohol misuse, 5% higher. And blood pressure, 5% higher as well. So this is what we call severity data. The previous graphic you saw is frequency or prevalence data. And what we end up doing is realizing that these are individual variables, health risk variables. When we combine them, which we do in most people have multiple health risk, then that multiplies their cost relationship rather than adding it. So this is the part of our how does worker health affect the bottom line? If a part of that effect on the bottom line comes from the range, the prevalence and severity of risk factors that are current in our working population. So again, this is some of the best, newest information that's been provided in 2013, looks at 341,000 people, multiple employer across the US, and this really helps us understand more about the prevalence of health risk and their severity in terms of driving healthcare costs. Now, this next graphic is from a study done by a group of actuaries, and this is Bolnick, Millard, and Dugas. And the name of the article is Medical Care Savings from Workplace Wellness Programs, JOEM 2012, and it uses the World Health Organization Global Burden of Disease data and health and risk factors data and study, and the medical expenditure panel surveys of the National Center for Health Statistics. So this looks really at some of the national and international data that asks the question, if we were to use the theoretical minimums that are now being reported in the literature for worksite wellness programs, what percentage of total health plan costs in different age categories would be potentially preventable? And the one to look at probably the most is this one. All workers, about 18%. So 18% of all of our health-related costs, that's primarily in the medical reimbursement portion of workers' comp and our health plan cost, are potentially preventable simply given the minimum performance of the interventions that we know about and have reported in the literature. It does not really deal with the issue of if you designed the program exceptionally well and implemented it exceptionally well, how much of the percentage of those costs could be reduced. In my experience, it's been more in the 40s. So they're high 30s, low 40s in terms of the percent of health plan costs that are potentially reducible if we were to look at the theoretical maximums rather than minimums of what is reported in our literature. The next issue is the prevention, do the math. And this is data from 2 years of observational data from the Kaiser Family Foundation. It shows you the 2015 and 2016 costs. The green indicates the employer portion of family medical premium, and the preventable portion of that 18% that we looked at on the previous graphic. That 18.4% was in fact related to the portion of these costs which are potentially preventable given minimums, theoretical minimums in our literature around the intervention around wellness programs. So what it's saying is this is the portion that it would reflect if we were to use those minimum interventions that have been documented in our literature. And this really builds on the Bolnick article, and the asterisk indicates the projected cost. That's the 2017 cost at the time that this particular graphic was made. The 2017 amount was projected rather than actual. Now let's do the math on another portion of activity, and this is the Kaiser Family Foundation 2016 report on 2015 and 2016, and then it projects 2017. And it basically shows the average premium, the average employee premium has been going up at approximately 4% or so a year. And the amount that the employee pays is in the light green portion. It's the employee share. So it just says that in addition to the potentially preventable amount that we're dealing with, we also have to add the portion that is paid for by employees and the potential of reducing some of the employee share of cost savings or cost sharing on their health plan cost. So another part of our worker health and bottom line issue is as employees pick up more of the cost of their health plan, if we can in fact help them be healthier through a wellness program, we can reduce some of that increased cost to them as well as to the employer. Now, the financial impact of selected health risk factors we're going to look at is from a study, again, done by these authors, and it's the relationship between 11 health risk and medical and productivity cost. That's really presenteeism cost for a large employer. Published in the 2011 Journal of Occupational Environmental Medicine. This included a sample size of 63,000 people. So this is very large population data that tells us what the medical plan cost is for various health risk issues, the sick leave cost, which is in the blue, and the presenteeism, which is in the teal. So we have a combination for blood glucose of a differential between the person who has a high elevated blood glucose and the person who does not of somewhere around $4,000, so about $3,952. If they have elevated blood pressure, it's about $1,257 higher for the person who has the elevated blood pressure. If they don't exercise, it's an additional $1,365 related to these three major variables. And then if they report either tenuous or difficult emotional health, in terms of anxiety reactions or depression, or sleep disorders that are secondary to psychological reasons. They in fact experience a $1,675 increased cost per year of someone who has that particular risk factor versus someone who does not. And then obesity, if they're reporting I believe the threshold here is a BMI over 30, we're looking at a $580 increase in cost per year for that individual. For elevated triglycerides, $529, and elevated tobacco use, $604. So again, you see the proportion between medical costs, sick leave, and presenteeism related cost for selected health risk. So again, part of our building the case for worker health in the bottom line is to recognize that those risk factors that are highly prevalent in our population do in fact have an excess risk premium or additional cost attached to them. That additional cost can be measured in medical plan costs, sick leave absenteeism cost, and presenteeism cost. If we had the data and the study had been included it, we could have had the disability cost as well as the workers' comp cost included in this. And that would again push up all these numbers to a much higher level. Now, the cost difference between high and low risk individuals for these particular listing of risk factors. This is 2015 health plan dollars. So what we're looking at again is the 1998 October brought up to 2015, and it basically says if you report that you're depressed versus the person compared with that's not depressed, your costs are on average $4,500 more per year in terms of health plan cost. That's health plan only. Stress costs, you are going to have a $2,100 differential. Elevated blood sugar, 27, obesity, 22, smoker, 1,300, high blood pressure, 1,200, no exercise, about 1,300. So again, this is more data that relates back to our issue of being able to look at the increased cost of health plan coverage for individuals that have key health risk. Now, this particular data is health risk increased presenteeism cost exponentially in 2016. So this is 2016 related data. It was originally reported in 2009 and then updated using the CPI, the Consumer Price Index, between the years 2008 and 2016 of a total of 14.8%. So our CPI during that time period was 14.8%. That's been multiplied by the original finding, which included data on some 750,000 people. And it just shows you the dose-related response of increased presenteeism cost as you increase the total number of health risk for which a person is at risk. So this is data that basically says that the more risk factors you have, the higher the presenteeism cost, the losses associated with your staying at work when you have an underlying health or wellness issue. One of the key bottom line issues of worker health has to do with the determinants, or what things actually determine how much healthcare use an individual needs and how those individuals are then put into a collective in terms of populations. So let's look at the factors that influence how much healthcare an individual uses as part of a group. We call this, by the way, an economic analysis that starts with looking at the supply side factors, those things outside the individual, and we are going to then look at the demand side factors, which are inside the individual. So it's a combination of internal things and external things that will determine how much a particular population and how much the people in a population will actually use in terms of healthcare services. The first issue, and by the way, a lot of this has come from the work of the Andersons, Odin Anderson and his son, that were at University of Chicago for a number of years. They basically did a lot of the research to surface these kinds of issues. One is the extent and scope of insurance coverage. So if our coverage is very narrow, we will tend to spend less on healthcare. If our coverage is very broad, we frequently will use more healthcare. In addition, the point of use cost sharing adequacy is also an issue. If I have a $5 copay on a generic prescription versus a brand name prescription, I'm not going to see a lot of use of that generic. But if the copay was $25 for the brand name, I would see a lot more substitution of generics. So point of use cost sharing issues are important. Same thing if I have a physician visit, office visit rate, or a copay, or a emergency room copay. Those things influence how much health care I choose to use. In addition, there's geographic access to services, and that's the issue of, are you in an urban, suburban, or rural area? If you're in a rural area, it's much harder for you to get to the services that are usually in urban and suburban areas. So that changes the context of how much healthcare an individual uses based on their geographic location. Another one of the supply side factors is regional or local practice patterns. So we know from the work of Winberg and others at the University of Dartmouth and Dartmouth University, there are a number of things that have been published in what's called the Healthcare Atlas that looks at differential patterns with the same diagnosis and the same patient characteristics. You see quite a range of days of hospitalization, types of drugs used, types of surgical procedures used. So there's a lot of regional and local practice pattern differences, and you can either be in a very efficient area or a very inefficient area in terms of healthcare utilization and cost. In addition, there are a series of provider incentives that affect diagnosis and treatment decisions. And an example of that would be something like a physician's office, a primary care doctor's office, where he or she has purchased a new piece of diagnostic equipment to be able to run what are called CBCs, complete blood counts. And so then all of a sudden, everybody needs to have a CBC done. So it becomes a screening tool because it's there, and the physician also benefits from its use. So those are called provider incentives that affect the diagnosis and treatment decisions of individuals. Now, you also notice as we go on to the demand side factors inside the individual, that there's an asterisk after a number of these. There are 3 of them that we just went through that have an asterisk. And that asterisk means that it's potentially modifiable by employer wellness efforts. So we can, in fact, change some of these things by teaching people about these issues or how to deal with them. So that means that they're amenable to change and amenable to wellness interventions. Now, the areas we're going to be looking at in terms of demand side factors are, first of all, the 2 most powerful predictors of healthcare utilization and cost is age and gender. So those 2 are very powerful. You'll notice also that the age has an asterisk on it, and it doesn't mean that we change people's birth certificates. It means that if we help people with wellness programs and help them to age differently, by being more active or maintaining their weight or changing their diet or handling alcohol differently or stress differently or not do distracted driving. We in fact can change the pattern of utilization that is usually associated with age. So age and gender are 2 of the most powerful predictors, but age is not immutable. It in fact can be modified by the choices that we make as we age. Another one of the characteristics here is the sense of responsibility for personal health. So if we do not feel very responsible for our health, we're very fatalistic about our health, then we're not going to ask questions or get involved. We're going to basically be very dependent and or just accept whatever happens. Clinical risk factors are one of the issues that also affects utilization. So we know from some of the data that we've just shared earlier in this module that there is a differential use of health services depending on what clinical risk factors people have. In addition, there's also a current morbidity. So the way in which my pattern of healthcare utilization, perhaps my genetic background, my family patterns, and how they taught me to use healthcare services, there's a number of those kinds of issues that shape my current utilization and healthcare experience. So that is oftentimes what actuaries want to know. They want to know what your age, gender, and past experience with healthcare is in making an estimate of what kind of funding is needed to pay for your healthcare. The next area that we look at in the demand side is self-efficacy, and that relates to work by Albert Bandura and others that have essentially looked at the level of confidence that one has about making decisions about their health and well-being and or their family's health and well-being. So the higher that self-efficacy is, the more confident I am about taking a role, being involved, and shaping my experience. So that also affects my utilization. On the female figure, the gender is obviously a significant issue, and there is a gender difference in healthcare use. It's somewhere between 3 and about 9%. So there's a greater utilization for mainly two reasons. One is reproductive function, so that causes women to use services differently than men. The other issue is that women tend to take better care of their health than men do. Men are more attuned to ignoring things or not addressing health-related issues. They essentially tough it out or they ignore it. So that then changes the pattern of utilization that we frequently see in healthcare utilization. And then the personal health behavior is another area, and that's where we have risk factors and we have issues about how people utilize things like seatbelts or whether they adhere or use medical self-care skills and actually check out symptoms and try to figure out what the best thing to do is. So there's a number of different personal health behaviors that again it's got an asterisk next to it, so it has to do with something we can work on with our wellness activities. And finally, the attitudes about personal health care and healthcare use are also shape our utilization. So if I am a strongly union individual and I feel like my union is paid for my health care, I'm going to go ahead and use it because I'm going to perceive that I get more benefit out of using it than not using it. So I don't conserve it, I will use it. So those are attitudes or examples of attitudes that shape our healthcare use and our health and attitudes around our health. So in summary, these are the major determinants of what determines how much healthcare use an individual needs, and when it's put into collective terms, it becomes what the population needs. And it's divided into supply side factors, which are usually outside the individual, some of which we can affect with wellness, and then inside the individual, almost all of which we can affect through wellness programming. So this is again an important summary because these are the issues that influence how much healthcare utilization and how much stabilization of healthcare costs we experience when we do wellness in working populations. Now, we also need to remember as we think about the role of worker health and the bottom line influence and the bottom line effects is there are different ways of doing wellness. And if we are doing wellness in the feel-good model, it's not likely to have a lot of healthcare utilization and or cost effects. It's got primarily morale effects. If we're in the traditional model, we may see some effects on sick leave absenteeism and healthcare costs, but it's not going to be as great because our approach to wellness is much more, in a sense, haphazard with that traditional wellness program model of having a smorgasbord and a bunch of activities. We carry out the activities in wellness. Our program is very activity oriented, but not necessarily very results oriented. Then if we decide to do wellness in a more serious way, we frequently then start to have the main features that you see in the middle of the results under the results-driven wellness model or strategy. And that becomes much more of a producer of results. So we end up seeing more substantial results from wellness programs that use that particular strategy or program model. So our relationship to bottom line is also related to how we choose to do wellness in a specific population. Now, the value proposition, if we summarize a lot of what we've covered in this module, of the results-driven wellness model particularly, the results-driven wellness model uses health risk reduction, and that's where we are working on actually reducing the prevalence and severity of major health risk. It also can use a more targeted approach to benefits education. It's being able to educate people about their benefits, how to utilize them effectively, how to conserve them, how to make them last, how to be able to carry them forward. So it's more targeted benefit education. In addition, there's plan design modifications. So we can in fact modify the way that our plan is structured so that it leads to more efficient use. We can also, as part of our wellness strategy, have a number of individual interventions. So there are people we can target and recognize through our things like screening or like use of a well-being assessment or well-being survey that allow us to reach out to proactively to that individual and actually help them with specific issues. And then finally, another one of our approaches in the results-driven model is to use employee wellness incentives to help structure a number of different aspects of involvement and outcomes. So we can use these 5 different kinds of pathways, if you will, to produce some of the things that you see over on the right-hand side. So these, again, are pathways to changes in health plan cost, changes in healthcare utilization that drive those costs. And they include a lower prevalence of health risk, lower severity of health risks that are there, changing some of the attitudes around how people experience care, desire care, choose to use care, improved self-care, so particularly medical self-care, can be improved by our teaching people some ways of being able to do it in a way that produces better outcomes and produces a better and more scientific approach toward treating whatever symptoms that they're experiencing. The issues around being more assertive with providers so that you ask questions and you engage and you not just take a very docile or calm kind of perspective, uninvolved or apathetic perspective, but you actually have some involvement and engagement with healthcare providers. You can also consider less expensive options. So there are ways of substituting various activities in healthcare that lead to lower healthcare costs. There's also ways of minimizing unnecessary care use. A fairly significant portion of American healthcare is unnecessary by clinicians' vantage points. So when clinicians look at whether a physician visit was really necessary, whether a hospital or emergency room visit was necessary, whether the drug prescription was necessary, many of those things are not done because they are clinically appropriate. They're done because of all these things we're talking about as determinants of health. We also can help people resist some of the excess revenue generation that takes place in our healthcare system. Since we rely on the healthcare provider to determine what it is we need, we're not in a role to necessarily say, do I really need that? And there is also very little reason for me not to, or to say no. I'm not paying for it. My insurance is generally paying for it. So that leads to excess revenue generation, and we actually can teach people how to spot that and how to say, no, I don't need to have that additional set of x-rays, or no, I really don't need to have that prescription written because I'm probably not going to fill it. And then use less costly alternatives. So there are ways of substituting and using less costly alternatives. There's the fewer injury events. So I, in fact, can be more careful and not experience what are called iatrogenic risks that come from my contact with the healthcare system. If I am hospitalized, for instance, there are lots of people in the hospital that have serious either bacteriologic or viral infections. So I sometimes pick up an infection when I'm in the hospital. So if I'm not careful and not watching, I can in fact be injured. And that's what the Leapfrog project has focused on over the years. Also, if I take some steps, I can actually have a faster recovery. So there may be some things that I can do to speed the recovery process. And I can also get less heroic care. If I've got an advance directive and I've thought about some of these things and I'm in a situation where it's end of life, I in fact can have less heroic care leading to lower cost. I can also have less expensive options used. So these again are some of the ways in which we can structure results-driven wellness. We can put content into it that allows people to have some skills that take them down some pathways that are going to have a larger and more significant impact on healthcare utilization, and our healthcare utilization drives our cost. Now, the summary of bottom line issues in worker health are these. Health plan costs will likely continue to increase at 3 to 6 times the consumer price index as changes to the ACA are made. So we're in an era where we're waiting for some of the changes to take place in terms of the election, the 2016 election, and that is likely to cause us to move into that area. We have been in this area where it's been 3 to 6 times the CPI. That's likely to continue. So that means that our rates of increase in healthcare costs are going to be higher than most other elements of the production function or of our work process. Health risks significantly drive up health plans, sick leave, workers' comp, disability, short and long-term disability, and presenteeism costs. So we have this phenomena that we know from our epidemiologic literature that health risk generally push those costs up. There are a few that lower them, but not many. Most of them increase over time. And if we don't do anything with people, we're likely to see increased utilization happening just because of the aging process and the fact that we tend to go from low risk to moderate risk to high risk. If nothing is done, they will all go up significantly, and that's the outcome of what happens if we don't intervene. Employers pay the major portion of these costs, and it amounts to more than $30,000 per employee per year when you add up the 5 different variables. These costs constitute a large portion of the after-tax profitability of all businesses, all U.S. businesses, or revenue surplus, net revenue for government and nonprofits. So these costs are actually a large portion of what we have left over in our organizations. The desire would be to have more left over so that we have increased profitability and we in fact have increased surplus and or net revenue in the nonprofits and governmental sectors. So that's the problem we're faced with, is healthcare costs as they get larger consume more of our economic wealth and leave us with less to operate with. There are many other ways besides health risk reduction, which has been the foremost and major way in which wellness programs have reduced healthcare costs over time, that wellness programs can lower health-related costs. And that means all 5 of those costs that you saw in the bullet number 2. So there are other ways, and if we don't use those ways, we won't have an effect on those costs. We need to be able to use them. Results-driven wellness programs affect all of these health costs. So we in fact can affect all of these by focusing our wellness efforts. And finally, worker health should be considered a strategic imperative for all U.S. employers. And wellness really relates to the bottom line. That's what our basic premise is here in looking at this data, this evidence, and I believe it's very compelling that we need to really focus a lot of our activities in a strategic way on our working population. Now, a summary of key points for this particular module. First of all, Health costs will likely increase as the ACA is repealed and revised. So I would not expect to see a lower healthcare cost in the future. I believe that what we will likely see is a higher one, primarily around the uncertainty and the way in which our markets are kind of caught between non-market solutions and market solutions. Health benefit costs are likely to continue increasing much faster than all other employer costs, so they are going to get our attention. There are 5 primary types of health-related employee costs. Those are health plan, sick leave absenteeism, workers' compensation, disability insurance, and presenteeism costs. Employers cover a major portion of the cost of worker health. And if no wellness is done by employers, all healthcare costs will likely grow at a high rate. So we are going to end up consuming more of our economic resources through employee health related issues. These health related costs have a major impact on after-tax profitability and net revenue. And there are many strategies and methods to change the health related costs of employees. Results-driven wellness is designed to lower all health-related costs, and particularly if your set of interventions, your targeting and your interventions are geared to do that. In addition to cost reduction, wellness programs can also affect many value on investment variables in a significant way. And those are opposed to the ROI or economic issues, which we've talked about primarily in this particular module. The VOI gets us into things that are harder for us to convert into monetary terms, but are also important to organizations like retention and recruitment of employees and morale and general productivity. Using a results-driven wellness program model or strategy has the effect of making wellness a strategic imperative for American business. Now, let's look at some key questions. My first question is, why do so many employers get stuck on tactical wellness programs? One of the things that I see across the horizon is that a major portion, 70–80% of what is done in the name of wellness in American corporations and American business is what I would call tactical wellness. It's where we're not very strategic in our orientation. We aren't addressing why. We're just basically doing a few things, a tap here and a tap there. And I think the major reasons that I think that this is the case is that American business managers and senior managers particularly don't generally understand the economic potential behind wellness. They perhaps have heard about it, maybe don't believe it, don't want to spend the time learning about it, or don't know that it is important. Secondly, that they sometimes perceive it's too complex to do it right. So when they start hearing about what they have to do, they oftentimes turn off and say, well, let's just do the minimum. Let's go for the low-hanging fruit. The third thing is they don't understand the different ways of doing wellness that are embraced in that 3-part strategy model that you saw earlier: feel good, traditional, and results driven. They also tend to underfund their efforts in wellness. They want to get by on the least amount of money. They want to somehow see big impact with very little resources, and that's generally not going to happen. And finally, I think that they have also sought a strategy of vendorization. They've taken the wellness efforts and said, instead of us doing this, let's get our health plan to do it, or to get a vendor to do it. And the vendor begins to take a sense of ownership over the program, but the employer and the employees in the company don't have that sense of ownership. So they end up staying pretty tactical oriented, doing the minimum, and not really being too concerned about the results of their program. So those are some of the reasons that I think employers get stuck on tactical wellness programs. Next question is, how should senior management be approached with wellness? And I think, first of all, here's the approach that I would suggest that we use with senior management. One, we approach wellness as a human capital enhancement strategy. That just like we have our capital and financial capital enhancement, and we manage funds, we manage our resources to maximize the outcome and the profitability of an enterprise. We also need to be being able to have the human capital enhancement take place. Secondly, I think we need to approach management with more of a strategic perspective by being able to look at productivity and the economic issues in more depth. The third approach, I believe, for senior management should be to look at wellness as it's how you do it, not necessarily just what you do, but it's how you do it. The third area, or the fourth area rather, is to have this be an efficient force multiplier. Most senior managers can understand the military kind of axiom and force multiplier. So it's the idea that you are increasing, you're making your forces, your labor forces, actually more powerful. You're multiplying them because you are increasing their efficiency. In addition, I would start and come at them with a factual basis. I'd want to know what our current costs are, what the patterns and trends are in terms of future likely to be, what they've been in the past, and be able to have that factual orientation to measurement and metrics. The next area that I think makes sense is to look at this as a way of getting to a balanced scorecard and using a results-driven wellness approach so that you in fact are balancing off the economic issues with the organizational issues that we think of as in value on investment. And the third question is, how should you evaluate the economic effects of a results-driven wellness program? I think you want to use all 5 of the economic variables: health plan, sick leave, absenteeism, workers' comp, disability, and presenteeism. I think you want to use a maximization kind of programming strategy. So there are ways of being able to maximize that health and productivity management effects that are reflected by those 5 economic variables. So I can use some maximization strategies, like for instance including spouses, so that they're on the health plan as well as the employee, and I can include them and do wellness for them, which really gives me a maximization kind of approach to the economic effects on my health plan. The next strategy is to use a results-driven wellness framework as the way of looking at the economic results, so that I can in fact track changes through each of the boxes in that framework. That gives me a higher likelihood that we're looking at the actual causal effects, the attribution of cause and effect in the wellness program efforts themselves. I'd also look at them in an annual view, but also looking at the time series trends which these organizations are likely to experience. So we want to be looking at how is the medical trend on our health plan over the last 3 years since we've been doing wellness. What's it look like compared to earlier patterns? And how does that compare with our peers or our companies that we use as benchmarks? So I want to be able to look at both annual performance but also time series trends that will help me see what that economic effect is from my wellness activities. And finally, I think I want to evaluate the economic effects along with the value on investment, the return on investment, and the value on investment effects, and that's called a balanced scorecard approach. So in business parlance, that's what you do, is you really get a balanced scorecard so you aren't loading up all of your measurement and all of your focus on certain kinds of utility. You get a balance between the economic utility and the humanitarian utility that comes with value on investment. So in summary, these are some of the answers to these key questions that relate back to our general topic of how wellness and worker health relate to the bottom line. Now that you completed this particular module, go ahead and take the quiz.